Next, I would like, it's exciting for me to announce these next presenters. Oh, for anyone standing in back who'd like to sit down, there are seats at the front table. I know it's like coming in to classroom and no one wants to sit in the front, but we don't bite, and you have a great unfettered view of everything that's happening. These next presenters are exciting not only because of the subject matter, which is a constant question for anyone with the adult form of the disease, but also because anyone who's been involved with ALD Connect in previous years knows one of the presenters, Camille Corre, who we're proud to say has gone, I probably mispronounced that, has gone and is in medical school now, but it's such an important subject matter and we're so honored to bring them back. So Dr. Gomery and Camille, welcome.
Hi everyone. Oh, am I too loud? Are we good? Okay. My name is Camille Corre. Thank you so much, Kathleen, for the introduction. I'm really excited to be here today with Dr. Gomery to speak about a topic that I think is near and dear to a lot of people's hearts in this room. This is a project that I worked on during my 2 years at Mass General. As Kathleen mentioned, I've since moved on and started medical school, but this is still a project that's very important to me and that we continue working on. Okay, so I wanted to start off by just giving some context about how this study arose, and really it was because of a lot of people in this room. So we heard time and time again through ALD Connect events, patient learning academies, community calls, as well as patients who come to the clinics at MGH, that as much as the popular understanding of AMN is gait and balance difficulties, what we heard time and time again is that it's actually urinary and bowel symptoms that have the most serious consequence on patients' quality of life. And hearing these stories just about how these symptoms affect patients on a day-to-day basis really motivated us to try to understand this better, just to do better by all of you so that we can have some data behind this. And so as we speak about this today, just understand that this is a first step in understanding these issues so that hopefully more progress can be made in the future in managing them. So just to give some background of what we're looking at and why there's a little understanding of these symptoms, essentially there's 2 large papers out there that have described these symptoms previously. So one of them only looked at women, one was men and women, and they did report that these symptoms are present and seriously impact quality of life. But we wanted to understand these better and add to both of these studies, as well as just some sort of isolated case studies that are out there with a systematic overview of how prevalent these symptoms are, what are patients doing to manage them, and what is the impact on patients' quality of life. So I will cover 3 different main methods that we used for our study. The first was a comprehensive review of medical records, just to get a historic understanding of what the prevalence of these symptoms is. We use that to then inform a very we use that to inform a targeted symptom study that we distributed to all of our AMN and ALD patients, where they returned the surveys to us and helped us understand better the impact of those symptoms on their quality of life. And then finally, I'll do an overview today of the results of some urodynamic testing, which was done by Dr. Gomery for a section of our patients. This is something that some people in this room might have had done before, and hopefully today we can help you better understand what that test is, what insights it provides to us, and how it helps us better understand these symptoms. Okay, so to start with our retrospective medical record review, we pulled the records of all adult ALD patients of all different phenotypes that were seen at MGH in the leukodystrophy clinic over a span of about 15 years. We recorded the prevalence and age of onset of a list of symptoms up here. We chose these symptoms based on our anecdotal understanding of which symptoms are most important to patients, and then we further narrowed that down by using internationally standardized definitions for those symptoms to make sure that we're presenting research in accordance with what is already out there. So when it was reported, we recorded the age of onset of each of these symptoms. As we're looking at all of the medical record data, we documented the first chronological documentation of the symptom as the age of onset. Some of you can imagine if you perhaps first go to see an ALD specialist later in life, maybe you're, in your 60s. Sorry, I know my mom's in the back of the room cringing as I say this. If you're sometime after you were diagnosed with AMN and you've already had a couple of symptoms develop, we might not know exactly when they started. So just keep that in mind as we present this data, that it is looking backward, and so we do have to keep that in mind. Okay, so these were the, again, symptoms that we looked at. So we looked at urinary incontinence, frequency, urgency, hesitancy, and retention. And then for bowel symptoms, we looked at incontinence, urgency, constipation, and diarrhea. And again, we used those definitions that have been standardized by an international organization. Okay. So based on our results from the retrospective medical record review, we designed a survey that was going to ask about those same symptoms in a similar way as the way we were looking at historic records. So we developed this survey. We tried to make it as user and patient friendly as possible. We mailed it out to all of our patients. We had an unbelievable return rate, so thank you to the motivation of the ALD community for helping us put this research together. We also distributed the survey to a number of family members of ALD patients that were seen in our clinic, who also carry an ABCD1 mutation themselves. We asked about medications, different interventions that patients have tried to manage their symptoms, and then most importantly, we asked one question at the end about impact on quality of life. Okay. So then the final part of our study was looking at these urodynamic studies that were done as part of standard of care. We thought this was a pretty unique opportunity to pull this data together. This is something that really isn't in the literature currently, aside from a few isolated case studies. And we wanted to see if any patterns emerged to help us understand why adult ALD patients present with these symptoms. So just to understand exactly how we do that, Dr. Gomery performs all of these studies according to a very standardized, rigorous protocol that's the same for all patients. He performs the test with the help of a technician. Essentially, it first involves the patient going in and completely emptying their bladder, and then filling the bladder at a very controlled rate. And as we do that, we can look at different pressures that are measured with sensors, and understand what are the changes in pressures in the abdomen as your bladder is filled, what changes as you start to empty your bladder. Do you lose control at any point? And you can kind of compare what is the volume of the bladder when you first feel the sensation to void. What is the volume at which you feel like voiding is completely uncontrollable? Just to compare those to otherwise healthy patients and see what we can learn. And then just to get a sense of the vast amount of data you can collect from this test, this is just an example of one of the readouts, but we'll look at those a little bit more carefully later in the presentation. Okay, and so then just to walk you through a little bit more carefully what we do in those urodynamic tests, this is just a collection of some of the different tests that are run. We'll run through a couple of them later on to, again, look at exactly what is going on with ALD patients. But as I mentioned, we start off by just having a patient void normally, followed by filling the bladder at a controlled rate, at which point you can measure these different volumes at first sensation, first desire to void. We can understand how much does the pressure of the bladder change as the volume changes when we fill it. We can understand if there are any bladder outlet obstructions, if there's any dyssynergia between the detrusor and the sphincter, and then we can also look at the anatomy of the bladder through imaging. So to present what we found in our study, this is a schematic of the patients in our entire cohort. So as I mentioned, the first step of this study was just to understand what data we already had. And so if you look at the green oval covering the majority of the screen here, that is 103 patients. And those are the patients that we started out just by looking at medical records. At that point, we developed the survey. We distributed that to all of the patients. Of note, a number of the patients might have since moved away. We might not have updated contact information. They might have passed away since they were last seen. So it wasn't possible to get a survey back from every patient, but we were lucky to have a pretty great return rate. So then the overlap right over here shows the patients who returned the survey, and we also had medical record data. So for that really rigorous group, we had two sets of data to compare. At the top, we do have, we had 6 patients who were family members of patients seen in clinic. They had never been seen as patients themselves, but they agreed to fill out the survey. And then right in the middle, we have the 12 patients I'm sorry, there's a typo on there. That should be 11 patients who underwent urodynamic testing, and we'll see those results later on. Okay, and then to understand how well we were able to capture the entire ALD population, on the left over here we have a schematic covering all of the different phenotypes. So we do have almost all of the adult phenotypes represented in our population, ranging from patients with absolutely no symptoms, whether those are related to gait and balance or bladder and bowel symptoms. We have patients with cerebral involvement, some of whom are symptomatic, some of whom are not. Some of those patients had received a transplant, some as adults, some as children. And so we were able to cover a pretty broad range. And our data set was pretty evenly matched between men and women. On the right, we just have the age distribution, so pretty normally distributed and covering an age range from 18 to over 80 years old. And then of those patients who were seen in the MGH clinic, we had patients, a number of patients who were only seen once, perhaps a patient who is coming to Boston from far away and isn't able to repeatedly travel or make that trip. We also have a number of patients who have been seen on multiple occasions, so we have that longitudinal data. And then 16 of the patients were referred to see Dr. Gomery in our neurourology clinic at MGH as well. Okay, so to start presenting what we found, this chart represents the cross-sectional prevalence of symptoms in our population. So this means that in our patient population with that broad age range that we looked at right back here, at the point in time that we collected data, how many of them had a given symptom. So we don't want to necessarily say, look at this data and say that this percentage of patients will develop a symptom. It could be that some of the patients who didn't have a symptom at this point in time will go on to develop one, or vice versa, but just to get a sense of how prevalent these symptoms are in our population, even just looking at one point in time. And then in case you can't see the legend, it's a little small, the leftmost column for each symptom is our whole population, followed by men and women. So you can again see that women are affected by these symptoms, which we know has been a pretty hot topic, especially at our ALD Connect meetings, that women are suffering from these symptoms just as the men are. Okay, so now tracking over the lifetime. It's great to have that cross-sectional view of symptom prevalence, but we really wanted to understand what is the patient's likelihood of developing a symptom. So we used an analysis that allowed us to track over time what is the percent of the population that has a symptom versus the amount of the population that could potentially have that symptom at a given point in time. So as I mentioned earlier in the presentation, we were relying on a data set that had a couple of holes in it, right? If I asked any person to tell me exactly the age at which they started to develop a symptom, the likelihood that you wrote that day down on your calendar is non-existent. So we need to understand that these symptoms are evolving over time, and it's hard sometimes to pinpoint an exact age at which that symptom developed. So again, if a patient presented to clinic a number of years after a symptom presented, they might just say, oh, I remember it started in my early 40s. And so in that case, what we did is we used a systematic way of coding those age ranges to keep it consistent. So I think if a patient said early 40s, we would have coded that as the symptoms started somewhere between age 40 and 42, and we kept those consistent over time. But just to account for that variability and make sure that we're not losing the accuracy of our data, for each model here, we presented a best and a worst case scenario. So the best case scenario would be, what is the latest possible age in that age range that the symptom could have developed? So best case is in blue in these figures, it's the bottommost line. And then worst case scenario was, what is the earliest possible age at which these symptoms presented? So we can imagine that the true incidence is going to be somewhere between the blue and the green lines. So this screen right here is the onset of the urinary symptoms, followed by the incidence of bowel symptoms. I'll have a graph in a couple of slides that pulls all these together so you can see all at once. And then this figure shows the presence of at least one symptom. So on the left, at least one urinary or bowel symptom, at least one urinary symptom, at least one bowel symptom. And so these, you can really see that the onset is much more skewed towards the beginning. One thing I do like to point out, if you see a very sharp jump at the beginning of any of these graphs, that's because in some cases a patient might present with a symptom unrelated to ALD. And we don't necessarily have any way of saying this was ALD versus this wasn't. So if a patient said, oh, I've had this symptom since childhood, that would contribute to this data set as well. So if you see that jump, in a lot of cases that would be around 5 to 12 years old, because that's how we coded childhood. So just keep that in mind. So this is that figure that's going to bring together all of the symptoms. So essentially we can see the age of onset. Towards the earliest age of onset would be for at least one of any of those symptoms. Then we tried to plot them out over time, which symptoms are developing in which order. We still have some work to do in better defining which symptoms are the first to arise, but really the main takeaway here is that these symptoms are increasing with age. They're presenting at an early age, and we hope to understand them better. Okay. So in response to our question about quality of life, we had some interesting findings. So 72.3% of patients who had at least one urinary or bowel symptom said that it had some effect on their daily quality of life, which, as you'll recall, is the main reason we did this study. We wanted to understand what is the effect of these symptoms and how can we help patients better manage them. Of those patients, 40% reported a moderate to severe impact on quality of life, leaving only just under 30% of patients who had a symptom and said it had absolutely no effect on their quality of life. Something else interesting that I found is that sometimes patients would report a number of different interventions they had tried to manage these symptoms, and then might still say it had no impact on their quality of life, which to me is interesting because it kind of says, it's affecting me enough that I want something to do about it, but it's affected me so much that I don't think that it's affecting me anymore, if that makes sense. So I think it says a lot about the resilience of our patient population in saying that, I've learned to manage it, it's fine, it's not affecting me, even though when we look at it, we say, but you seem to have changed parts of your life to accommodate for these symptoms. So these, I think, were some of my favorite pieces of data that we collected from the study. So there were a couple of targeted questions that we were able to ask on the survey that we couldn't necessarily go back and collect from medical records, so we wanted to ask them in very targeted ways. One of those, is there a glass of water I can grab anywhere? Thank you, sorry. So the first was in regards to urinary frequency. Some of you might recall from one of my earliest slides that the internationally accepted definition of urinary frequency is kind of interesting. So it doesn't give a specific number of this many times you void in a 24-hour period says you have urinary frequency. The accepted definition is actually what a patient perceives to be abnormal. So it can be very different for very many people, and it's hard for us to have someone report, I used the bathroom this many times in a 24-hour period, and us to say you do versus don't have urinary frequency. So in a better way to sort of compare one patient to another across the whole population, what we did is just ask patients, how many times in a 24-hour period do you have to void? And we looked at the data. And so what I found was interesting was that 10 was the average response, with a range of 5 to 20 in a 24-hour period, which, if you consider that not all of those are waking hours, seemed relatively high. And then the second two pieces of data that I found particularly interesting are in patients who reported urinary urgency and also reported urinary incontinence, and then the same thing for fecal urgency and fecal incontinence. We asked patients, in this situation, approximately how much warning time do you have between the time you say, I need to use the restroom, and the time when an accident is completely unavoidable? And what we found was that for urinary urgency causing incontinence, patients reported a mean warning time of 4.1 minutes, with a range of 0 to 30. And then for fecal urgency leading to incontinence, we found a mean warning time of 3.1 minutes, with a range of 0 to 10. So this, more than anything else, I think really made me stand back and look at my own life and say, how many times in a day are there where I would not be able to get to a restroom in 4.1 or 3.1 minutes, and how would that affect my quality of life? In just trying to think about how is it that you go to work and go about your day? How is it that you go grocery shopping? How is it that you carry on these tasks that we all take for granted so much when you inherently might have to build your life around this? So that's something that I think was very humbling for me in understanding the situations that some of our patients are facing. Okay. So moving on to medications and different ways to compensate for these symptoms. Again, I think it's particularly interesting when you consider this hand in hand with the fact that not all patients report that there is an impact to their quality of life. So let's look at what actually patients are doing to try to ameliorate these symptoms or accommodate their lives around them. So we found that 51.5% of patients have tried at least one medication, whether a prescription medication or something over the counter. We have a breakdown of a couple of the different classes of medications. So by far the most common were different constipation and bowel supplements, which just under half of our population that was symptomatic had used at least once. For non-pharmacologic interventions and lifestyle modifications, we found that just under 72% of patients had tried at least one of these, ranging from things like using a leak protection pad in case of accidental incontinence, to pelvic floor physical therapy, catheterization, and then lifestyle modifications like restricting or limiting one's caffeine intake, food intake, fluid intake throughout the day, and planning one's daily schedule around proximity to a restroom. So again, just trying to remember what is it about someone's life that changes because of these symptoms, and really trying to understand, if you have to do all of these things to get to a point where you feel like your quality of life isn't affected, can we really say that your quality of life isn't affected? Okay. So now to wrap up, to talk a little bit more about those urodynamic studies. Given that this is the Patient Learning Academy today, I wanted the focus of this to be, if one of your physicians were to recommend that you get a urodynamic study done, you might be thinking, why? What is there to be gained from this? I don't really want to do it. And so I just wanted to illustrate how valuable that data has been to us in understanding these symptoms in ALD patients, and how it could potentially provide insight into your own case and help your physician better guide first lines of treatment. And this is a topic that I will definitely defer to Dr. Gomery for any questions. He is an incredible expert on this topic and has taught me so much, but he has a lot to add to the conversation. So, on that note, this is a summary of all of the different urodynamic studies that we covered through patients in our study. So we had 11 different patients undergo urodynamic studies. It was a mix of men and women ranging from their 20s to their 80s. We did have one patient undergo a repeat urodynamic study, and I'll go over that interesting case in just a moment. But if you could just take a second to appreciate this just summary of the data and all of the insight that it provides. So rather than just a test providing one data point about what is the one thing we can change as a result of this, a urodynamic study really provides a holistic understanding that can help you pinpoint exactly what it is that is going wrong in your case and what treatment might be effective for you versus another patient. Something I find very interesting. Okay, so the first case I want to discuss is the patient on here, patient 4A. So this was the only one of the 11 patients who had a normal urodynamic study. Interestingly, he's also the only patient who had symptomatic cerebral disease at the time of his urodynamic study. So obviously this is an N of 1. I don't want to draw any hard and fast conclusions, but one interesting topic to consider is whether his lack of symptoms at this point might be attributed to the fact that he had potentially not developed AMN symptoms at this point, and whether his symptoms might be more attributed to lingering symptoms of cerebral ALD. So interestingly, this patient also underwent a repeat urodynamic study I believe a couple of years later, about 1.5 years later, at which point he did have an abnormal urodynamic study. And so again, N of 1, but it is just interesting to start to consider what is the difference between the impact of cerebral ALD versus AMN in these symptoms. And I think that's just an interesting case to think about. Okay. So another conclusion we can draw here is that it's tough to draw conclusions. So we didn't find one specific finding or one phenotype in all of the patients we looked at. Rather, we found a vast array of different presentations. The most common one that we found was neurogenic detrusor overactivity, but as I walk you through, I'll show you a couple of other findings that we found. So I think the major takeaway here is that as much as we wanted to look at this data and say, this is what happens in adults with ALD, that's not what we found. And we actually found that patients present in very different ways, which might suggest that we need to treat different patients differently with different medications and different coping strategies. Okay, so just to return to, just to return to the different components of a urodynamic study. I don't want to go through every component of one because, as I mentioned, there's a whole lot of data to pull out of them. But just to go into 3 different components of it to give you an insight into what we can learn from the urodynamic data. So the first one is the complex cystometrogram portion of the study, which is where we're filling the bladder at a controlled rate. So we can consider that in this equation down here, we're controlling the change in bladder volume, and then we're evaluating what is the difference in detrusor pressure as we're doing that. So in a normal patient, as you fill your bladder, your detrusor pressure is not going to increase. It's going to maintain itself at a pretty constant level until the point at which you get ready to urinate, at which point it will go up and then go back down. What we found in our patients is that a number of them had abnormal compliance, which means that their detrusor pressure is not changing in the way that we expect it to as we're filling the bladder. Another component of this study is that we looked at the volume of bladder at which a patient felt the first sensation that they might need to void. Next, the point at which they first had the desire to void, the point at which they had a strong desire to void, and then the point at which voiding became uncontrollable. So, if we look here, I pulled some data from one of our patients with a normal urodynamic study in the bottom right corner. So this is looking at detrusor pressure as we fill the bladder. So you can see this very abnormal up and down, compared over here to a relatively flat line. So the next thing we found was that 7 of 11 patients have phasic detrusor contractions. So again, we're in a normal patient. We would expect to see sort of one up and one down. In these patients, we are seeing some very irregular contractions, which you can see on this slide right here. Again, compared to, actually I don't have the normal on this slide, but again, you can see the up and down. In one patient, we also found terminal detrusor overactivity, meaning that we saw that overactivity close to the point of voiding on the right of the screen right here. Okay, and then the final component is just to look at different abnormalities on imaging. Fun little fact that I learned while doing this study is there is an abnormal finding when you do imaging during a urodynamic study of what's called a Christmas tree bladder. So I just put that image up here so you guys could see what it looks like. But sometimes I think it can be really validating to sort of feel a symptom and then see something that tells you, oh, this is why I feel that way, and this kind of explains it. So I just thought this was sort of an interesting thing to end on and just see what is one of the possible presentations on imaging of these urinary symptoms. So to summarize, key findings from our study. We find that urinary and bowel symptoms are highly prevalent in both men and women. We find that they increase steadily with age and that they do impact disease burden and quality of life. We find that patients have tried a variety of interventions, both pharmacologic and non-pharmacologic, but overall only about half of patients who are symptomatic have tried at least one medication. We find that the mean onset of these symptoms occurs somewhere between 39 and 54 years of age, but patients presenting with at least one urinary or bowel symptom at a mean age of 24 to 35. Finally, just tying this together with our broader understanding of AMN in adults, we know that gait and balance impairment is a significant part of this disease process. And so when we consider that someone who has difficulty walking, if you compound that with the very decreased warning times that we discussed earlier, you can imagine how these symptoms would have more of a burden on an AMN patient as opposed to a patient who is only struggling with urinary or bowel dysfunction. Finally, we understand that urodynamic examination provides a lot of insight into the complex presentations of these symptoms. Right now we have a limited set of data, but we hope this sort of opens the doors into better understanding of these symptoms so that we can do better by our patients and make sure that we're treating these with the best frontline treatments that will bring relief. Okay. And then just to wrap up, some next steps that we're continuing to work on as this project emerges more and more. We want to better characterize the sex differences in symptom onset between men and women. We did that a little bit with our cross-sectional view of the symptoms, but we want to understand whether the onset of these symptoms is earlier in men versus women. Is there any difference? Is there a difference in the medication effectiveness in men versus women, just so that we can understand that better. We also want to compare the progression of these symptoms to other neurologic conditions, as well as to healthy control patients, to understand, as we so often do in the rare disease field, whether there are insights that we can glean from other rare diseases or other common diseases, or perhaps whether there are insights that we can lend to other diseases to sort of join forces and avoid duplicating efforts. And then just to wrap up, I just wanted to put a slide to acknowledge some very important people who are part of this project. The first, and it absolutely would not have been possible without these people, are the patients. So I thank from the bottom of my heart every person who was a part of this project. I was really amazed to see just how motivated people were to participate, to share very personal things with me. I don't know that I would have felt comfortable bearing my soul to this survey that asked about a lot of very personal details. So I really thank any of you that participated in that. And then I want to thank the team that made this possible. So Dr. Gomery, who was so gracious to attend today, has been an absolutely incredible mentor along with Dr. Eichler. They've both taught me so much about ALD and about understanding these symptoms. They're two people I look up to incredibly, and I'm really thankful for their guidance. I'd also like to thank Dr. Reza Saeed Sajadi and Katie Becker, who are part of the care team at MGH for ALD patients. Katie has been seeing all of the ALD patients, as many of you know, along with Dr. Eichler at Mass General for years, and she was a large part in the data that we collected. Dr. Saeed Sajadi is an adult neuromuscular specialist who's provided a lot of insight into understanding why these symptoms might be developing. And then Natalie Grant, who has been absolutely incredible in helping carry this project on while I've been very busy away at school. So thank you so much, and I would welcome any questions to me or to the very knowledgeable Dr. Gomery. Thank you.
So on the frequency that you guys tested on the frequency, the amount of urination and timing of things, you had a median age when some of these onsets started. But the men and the women were grouped together in that grouping. So my assumption, we all have to assume, but is that the men's onsets would be earlier than the women's. So did you guys separate that data at all to see if the medians were different?
So that's one part of the project that we're currently working on. So unfortunately I don't have it to throw up here on the slide, but that's the next step of the project that we're interested in understanding. We have separated men and women for that cross-sectional view, and we saw pretty consistent across the board, but we're really interested, just as you are, to understand whether the age of onset is different between men and women.
My last follow-up, I know from last year there was certain exercises and things that people can do to increase or to help them with some of those symptoms other than medication. So some of the people that were having symptoms, is there anything to add on to this trial later on to see if they were able to control their movements through physical therapy per se?
That's a very difficult question to answer because the field of pelvic floor dysfunction and physical therapy expertise in it is a relatively incipient field. They have a lot of there are a lot of efforts to try to figure out what to do with it, but it's still in its beginning stages, so it'll be a field of research as to what it can offer in this group of patients as in other groups of patients that have bowel and bladder dysfunction, and even in normals who, as they age, develop urinary and bowel symptoms. So it's a very difficult question to answer at this point, but there is an international group that has gotten together to try to figure out clinical practice guidelines in all these disease entities as far as behavioral measures, pelvic floor, therapies, etc.
Hi there. Quick question there. I see you have a list of pharmacological interventions here. Did patients report any one of these specifically that worked best for them?
You know, that's another difficult question to answer. I wish people would ask easier questions. There is no such thing as best. Obviously, what you see from the data is that it's very, very individual. All our efforts at pharmacological treatment are very individualized, and you have to understand that the drugs that we use have systemic effects as a result. We have to be extremely careful about all the adverse events. There are cognitive issues that come with these drugs. And we don't really have superb drugs that, you know, are magical bullets. One of the things that's not on this study, one of the so-called magical things is injecting Botox in the bladder, but we don't know what happens to different populations when we do that. So we have to be extremely careful about the things that we do. For instance, in Botox, we have 30 years of experience injecting Botox in the neurological population. We don't have any experience in injecting Botox in this population. Could it be a quote-unquote, like you say, best therapy? Maybe, but attempting it is an experience in itself.
And I wonder, Dr. Gomery, if you can maybe provide some insight to the audience about how the findings of a urodynamic study help you decide which medication to prescribe.
Absolutely. You know, because it's individualized and because the findings are so diverse, it helps us enormously to understand what drug to give to a patient, because you have to understand that when a patient tells us that he or she has X symptoms, that doesn't tell us what's wrong with the patient in terms of the pathophysiology of the disease. It only tells us the urinary tract only has certain ways of speaking to us: frequency, urgency, hesitancy, etc., incontinence. But that doesn't tell us, unless we do this physiological study, as to what exactly is going on in that pelvic floor. So unfortunately, we need to do these studies to find out what the best possible treatment is, and that is individualized.
Okay.
Well, I have seen you before. I have seen you before, Dr. Gomery. I guess you answered one of my questions, was about medical effectiveness. It's very individual, right? So the medication is different for every patient. That's what you're saying?
Correct.
Oh, okay. And about the it's called the sphincter. That's what closes and opens the urinary tract to like, or bowel thing to like stop it or to let it go, whatever. Do you know like what happens, the reason why, what changes, so to speak, of that bowel sphincter, that it's not doing what it did before? It's not like you have control anymore sometimes, and it just happens and you just have to go and you just have to run, or as mentioned before, what you was talking about, because of the walking gait, you can't run. So you kind of like, okay, I'm getting there, and you have to think of like a couple of minutes before you have to go. Like maybe you have to stand up already and being ready to go. So I don't know, but just like what happened to that function in the body, the sphincter?
I hope I understood your question. I think I'll try to answer it, part of it, and maybe Dr. Eichler can complement my answer because he's the neurologist. But due to the neurological disease, the nerves that activate the muscles in the pelvic floor, those nerves are affected. Those nerves are actually activating the muscle for the muscle to contract properly, whether to contract in the bladder or to relax in the urethra. And obviously that muscle function is no longer normal. Same thing happens in in bowel. And as a result, what would be really nice is to affect positively the nerves that are malfunctioning. Some of our medications and some of our treatments are directed towards that, but we need to better define these neural circuits that are affected and how we can change them or impact upon them. There's a lot of research in that arena as to figuring out, this is a black box in medicine, what do neural circuits look like? If you think of them, they essentially look like a computer, you know, they're just wires going all sorts of places, connections, they're synaptic connections between nerves, and something is awry. We don't yet understand exactly where these connections go awry, and we don't yet understand how to impact upon them, but there's a lot of work trying to define that. Does that answer your question?
Yeah, thank you, Dr. Montgomery, thank you.
Dr. Eichler, you want to add something?
Yeah, no, there's obviously a lot of complexity here. I think part of it is also the sensory processing, right? So it's not just the peripheral innervation, it's how signal travels through the spinal cord to brain. So I think we're really at an interesting point in time. I think what Camilla has done is fantastic and should lead to us really, now that this continent has been laid out, we need to go in and start defining things better. I think it's a great opportunity. If I may take that chance to actually pick up on a question of a colleague of mine who was saying, how can we compare urodynamic studies across different centers? And Dr. Gummy, what's your opinion on if you get results on urodynamic studies from another place? We do this with MRIs, right? We're sort of taking MRIs, we're assigning less scores. Is there a day we would assign a urodynamic score for AMN? And if you had, a study done at Hopkins and you had a result, would you assign a score and say this is comparable to what would happen at MGH? Can you speak to that?
A little bit. It's a difficult question because you're obviously talking about quality of studies. There have been efforts internationally to do that in order to publish papers that have standardized data. And what they did in most of these is to assign one center to be the central deciding place where where they decide whether a study is adequate or inadequate. Unfortunately, what happens in these studies is that a lot of the studies that are done, unless they're strictly done for this study, turn out to be inadequate. So that in all these studies, it's been very difficult to, say, take 100 studies that come in and say, 40 of them are actually only adequate. So it makes the work, labor output is enormous. And so, unfortunately, we're not yet at the point where we can say study at place X is as good as study at place Y. You have to have people who are dedicated to create protocols, exactly, and to stick to those protocols and to stick to the guidelines and to, and human nature is not conducive to discipline.
Thank you.